Hi, this is Mary Jarzabowski. I'm an anesthesiologist and intensive care physician at the Ann Arbor VA healthcare system. And with the help of my colleagues, I'd like to talk to you today about using anesthesia machines as ICU ventilators in the current setting of our COVID-19 outbreak. So I want this to be a succinct, quick reference for mostly for our CRNAs and anesthesiologists who will be helping in our new ICU setup in the PACU and using our machines that we're familiar with in a sort of different way and for different patients. So I want to understand why anesthesia machines in an ICU setting is different to our daily OR machine use. We'll review the unique setup for the anesthesia machine when we're going to be using it as a long-term ventilator, and then specifically talk about safety concerns with our anesthesia machines in this setting. And then we will review briefly the settings on anesthesia machines for ARDS patients. So we have Draeger Apollos and Draeger Fabius Tiros as our two that we have available to use. These are the specs on them, but actually what we found is our Fabius Tiros actually have a maximum PEEP of 20. So they're able to deliver quite a lot of support. You can see tidal volumes max there, and inspiratory pressure max is quite high. Not as high as ICU ventilators, but still a decent amount of support that's available. We'll be favoring the Fabius Tiros because of the smaller footprint, but we will likely have to use some of our Apollo machines as well. So why is it different when we use an anesthesia machine in the ICU? It really is a horse of a different color. I mean, our anesthesia machines all have ventilators as part of them, but their purpose is really to deliver the minute ventilation of a patient who has a very depressed respiratory drive as a result of our anesthetic delivery. So the setup is a circle circuit machine, and that's done to try and preserve anesthesia gases mostly. We usually expect this to be a short-term ventilatory period for an OR case. Even some of these longer cases, 12, 16 hours is kind of hitting the maximum of what these machines really are expected to do. And then because we're in general seeing healthier lungs, there are limitations in function, pressures delivered, modes of ventilation that our anesthesia machines can offer. Whereas our ICU ventilators are designed to encourage ventilatory support alongside a patient who has somewhat of an intact respiratory drive. So they assume a greater degree of pulmonary pathophysiology, but the idea is to support the patient while still encouraging spontaneous breaths, and the machine setup and programming is just more elaborate to handle that. They also have active humidification, which our machines do not. So they're not really comparing apples to oranges, but they are definitely different apples. Our anesthesia machines have passive humidification, often done with an HME. We're not sure how well that will fare out for long-term humidification of airways and preventing drying of secretions that could become mucus plugs. Our anesthesia machines are supposed to have a daily machine check while the machine has been powered down. There is no way to back up the patient's ventilation during this period. Also, if there is ventilatory failure or patient apnea, depending on which mode you have set, there's no guaranteed backup rate that kicks in. They're really designed, as you can see in the picture there, for an anesthesia provider at the bedside the entire time for supervision. And also importantly, there's no leak compensation. So if you have a leak in your circuit, you will empty your bellows and not ventilate your patient. Alarms should sound, but again, it relies on you being close by. ICU ventilators, on the other hand, here we have a prone patient. They do allow internal checks while the machine is still supporting the patient. Therefore, you don't have to disconnect the circuit. They also have backup modes with central monitoring. So a respiratory therapist or ICU nurse or physician can be, a few rooms away and still know that there's a patient with a problem with the patient's ventilator. So there's less direct supervision required. And then they do have safety features like automatic leak compensation to ensure that the patient's still being ventilated even if it starts to detect a leak. So we're going to talk about how to set up a machine for ICU use in a COVID-19 patient. I'm just going to walk you through it with a video, but we have a printout with a checklist for all of us, which I suggest we all use at the beginning until we get used to assembling the circuit in the new way and making sure all our safety checks are in order. Alright, so now I want to show you guys how to set up one of our anesthesia machines to be used for an ICU patient, because there are some notable differences from what we would normally do in the operating room. So we'll start with really basic stuff. We want the anesthesia machine plugged into one of the red wall outlets so that there's emergency power supply in case of a failure. So ensure that you're actually plugged into a red outlet wherever this workstation is. We have our oxygen and our air tubing plugged into the wall as well. And then we were actually able to scavenge in our PACU, which may be different for other hospitals. But all of those should be plugged into the wall. And then lastly, and very importantly, we need to check our oxygen tank in the case of ventilator, in case of pipeline failure, so that we have a way for the ventilator to deliver oxygen to the patient. Okay, from this point, you're just going to turn your machine on and put a circuit on like you normally would. These are our circuits that we use every day. And you're going to connect it to the inspiratory and expiratory limbs with your bag on as you normally would. Now, at this point, we have to add some accessories and take some things away to make this suitable for a COVID ICU ARDS patient. You're going to take off your elbow piece. You don't need that. You're going to take off the HME that exists. We're going to use a different one, and I'll show you why. So you're going to be left with your the Y piece itself here. Alright, so now you're going to add some new additions that we don't normally use. The first is a viral filter. We're going to place this directly onto the Y piece here. And these filters we're choosing to use are called SafeStar, and they actually have a CO2 sampling port here. So you're going to connect your sample line as shown. Okay. Ahead of the viral filter, you're going to place an HME, okay, to help the patient maintain humidification of their airways. So this is the patient side, followed by filter, followed by CO2 sampler. And then lastly, before you do your leak check, you're going to want to place a pleated mechanical viral filter at the expiratory limb of the machine. So you can take off your limb as you normally would. And that will sit there to protect the machine an extra step to protect our machines from contamination. So now that you have this in place, you are good to do your leak check like you normally would, noting that there are more places for leaks to happen because of these accessories we have added. So check your machine thoroughly. While your machine check is ongoing, your leak check is ongoing, make sure you pay attention to your CO2 absorber. These patients are going to be on higher flows for a long time, and we're expecting these to desiccate quickly. So make sure you're not seeing any color change or any concerns about the canister itself. Now, once your machine check and your leak check are done and you've passed, there's one more component we have to add upstream of this, which is an inline suction for the patient who will be needing suctioning without aerosolization. So this piece we have here attaches like so, and then you are ready to receive your patient. So this then will connect directly to your ET tube when you receive your patient. Okay, and that's your completed circuit. Other things to check, which are part of our standard machine check flow sheets that you'll see in a separate video, you want the APL valve set to what you're expecting the patient's PEEP to be. So I suggest a minimum of 10, and that if the vent fails, you'll be at least delivering 10 centimeters of water pressure to the patient until you're able to intervene. You'll then want to set your ventilator settings for what you're expecting, and hopefully you've had time to talk to the ICU team about this. And then lastly, as a safety check, we always want to have an ambu bag at the bedside in case of any issues. And our ambu bags will all have a viral filter and a PEEP valve attached in case we need to bag our patients. Thanks.
Thank you.
So now that you've seen the basic setup for our machines, I want to talk a little bit about the safety concerns for using these anesthesia machines as ICU ventilators. So problems we anticipate have to do with humidification buildup inside the machine itself. So because these are going to be used for longer periods of time, the likelihood is that we will see water buildup in the components, and that could lead to inaccurate flow sensing. We're going to be doing machine checks every 3 days to try and prevent this and detect it before it happens, but be aware that this is definitely a possibility. We're also not actively humidifying the circuit. That's not possible with our machines. So we'll use an HME at the proximal end near the patient, but do be on the lookout for dry secretions. If we start seeing drier secretions, patients will be at risk for mucus plugging, and we want to prevent that before it happens and becomes a major problem. We are going to be using relatively low flows, which over time in this circle system can lead to the FiO2 that we're actually delivering the patient being lower than what we are setting on the ventilator. So make sure you're mindful of actually checking the gas analyzer for its FiO2 and making sure that it is reflective of what you have set with your oxygen levels that you want the patient to be receiving. Higher flows, which we will need to use to try and keep the circuit drier, may desiccate our CO2 absorbance, so be on the lookout for that. We also need to be mindful that we do not have a central alarm station for these ventilators, so one anesthesia provider at minimum needs to be present in the PACU at all times while we are running these ventilators. In case of alarms, someone who is familiar with with these machines has to be present to be able to troubleshoot it and make sure the patient's okay. Also be mindful that we do not have a backup in the event of electric failure on these ventilators. So even if you inadvertently hit the power switch, the patient will not be ventilated at all. So really be mindful and watching these patients closely, and we will have, as you saw, an ambu bag ready at every station in case of any issues like this. And then also just to be aware that there is no automatic leak compensation with these anesthesia machines. So with all these extra components we're adding, like viral filters and inline suction, there may be small leaks, and over time that may lead to empty bellows in the machine and diminishing tidal volumes. So keep an eye on tidal volumes. Hopefully with the higher flows, we will avoid some of this, but we need to be mindful of leaks in the circuit. We mentioned at the start, or I mentioned at the start, that we wanted to talk about advanced vent settings on these machines that can be used and how to manipulate them. And really today I just want to talk about what you should set in an emergency with a patient who needs ventilation and you don't have time to discuss vent settings ahead of time. So if you get the word that you need to set up a station and program your vent, this is what we recommend starting at, and then adjusting based on patient size, habitus, and then the pathophysiology of their lungs at the time, which can all be set after the stabilizing them initially. So for the Apollos, we're recommending the volume autoflow mode with a tidal volume of 450. Obviously, we'll try and do lung protective ventilation with lower volumes of 6 to 8 cc's per kilo. But if you don't have time to calculate, 450 is a safe bet for most people. Respiratory rate of 18, PEEP of 10, 100% FiO2, and then set your oxygen flows to 5 liters a minute, which is what we will recommend as a minimum flow for all patients in the PACU ICU. If you are setting up a Draeger-Fabius machine, we recommend the SAMV pressure support mode with tidal volumes of 450, again a respiratory rate of 18, a PEEP of 10, but make sure that you're setting pressure support to 10 centimeters of water, and then again 100% FiO2 and 5 liters of flow of the oxygen. So in summary, these are not ICU ventilators, but understanding basic differences I think will help us to keep our patients safe and anticipate problems before they happen. Also, keep in mind this is new for all of us. Even though we know these machines, this is a new setting and a new off-label use. So let's follow our checklists, ask questions, and please raise flags if you see safety concerns, because it's possible you may be the first one to notice. And for all of us, I wish you all good health. May we all stay healthy and well, and our families too. All right, please let me know if you have any questions. Thanks.